Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 392 of our pharmacotherapy series, which majors in seizure disorders. The next clinical case reads, TBN, a 7-year-old, 28-kilogram boy, has had seizures since age 3 months. He suffered anoxia at birth. His seizures usually involve initial confusion and disorientation, shortly followed by generalized tonic-clonic convulsive activity. Despite treatment with carbamazepine at maximal tolerated doses and serum concentrations, 300 mg thrice daily, 9 to 11 micrograms per milliliter, he continues to have approximately 2 seizures monthly. Recent trials of topiramate and tiagabine as additions to his carbamazepine were unsuccessful and caused intolerable sedation and lethargy. During the past year, he has been admitted to the emergency department 5 times because of seizure flurries, consisting of 3 to 6 seizures occurring during a period of 12 or fewer hours. Although he regains consciousness between these flurry seizures, he remains lethargic. During emergency department admissions, IV diazepam was administered. This was rapidly successful in terminating seizure activity. TBN's mother relates that she usually can identify the onset of seizure flurries. TBN's behavior changes and he becomes clinging and whiny and hyperactive. She also indicates that the initial seizure in a flurry differs from TBN's typical episodes. Before the onset of generalized seizure activity, he experiences much briefer periods of confusion. In addition, the generalized seizures are longer and more severe, often with dramatic cyanosis, at the beginning of a flurry. So my question to you is, why is prophylactic or abortive therapy for TBN's seizure flurries indicated? What factors about TBN predict successful use of such treatment, and how can it be administered? Frequent emergency department visits resulting from cluster seizures are expensive and frightening for many patients and their families. TBN continues to experience seizure flurries despite carbamazepine therapy. He responds well to IV diazepam and has a caregiver who can identify the onset of seizure clusters. His seizure clusters appear to be distinct from the other seizures that he experiences. All of these factors indicate that a trial of caregiver-administered treatment to abort these cluster episodes is likely to be helpful and should be initiated. Rectal diazepam gel is available for home administration to patients with acute episodes of repetitive seizure activity. When diazepam gel is administered rectally, Peak plasma concentrations occur in approximately 1.5 hours and cluster seizures are often terminated within 15 minutes. Use of diazepam rectal gel is recommended only when caregivers can recognize the onset of cluster seizures, which are different from a patient's usual seizure activity, and when the caregivers can be trained to administer the preparations safely and to monitor the patient's response, e.g., respiratory status, after administration. Caregivers should be informed that this preparation is not for as-needed use with every seizure. It should be used only for identifiable cluster seizures or prolonged seizures. TBN's mother should administer rectal diazepam gel at the onset of identifiable cluster seizure activity. A dose of approximately 0.3 mg per kilogram, corresponding to a dose of 10 mg, should be given and repeated, if necessary, within 4 to 12 hours of the first dose. TBN's mother should be counseled on the administration of this product and given the patient package insert, which gives complete instructions for the administration of rectal diazepam. After administration, TBN should be monitored for at least 4 hours to ensure that no respiratory depression or other adverse side effects are occurring and to assess the effect of the medication on his seizures. The most common adverse effect seen with rectal diazepam is somnolence, occasionally accompanied by dizziness and ataxia. Respiratory depression is very uncommon. Buccal, and intranasal formulations of benzodiazepines are currently being investigated for their utility in aborting cluster seizures, and their use may address some of the barriers associated with rectal drug administration. Our next clinical case reads, MJJ, a 14-month-old girl, is brought to the emergency department after having a generalized tonic-clonic convulsion lasting approximately 5 minutes. The episode occurred in association with an upper respiratory infection. On arrival in the emergency department, her temperature was 39.5 degrees Celsius rectally. She was alert at that time. All laboratory and neurologic findings, including lumbar puncture, were normal. MJJ has no history of neurologic abnormality. Her 7-year-old brother suffers from both absence and generalized tonic-clonic seizures. So my question to you reads, what is the relationship between febrile seizures and epilepsy? How may MJJ's convulsion be classified on the basis of the data available? Up to 8% of children have a febrile seizure between 6 months and 6 years of age. Simple febrile seizures occur with a fever of greater than or equal to 38 degrees Celsius in previously normal children younger than 5 years of age. They last less than 15 minutes and have no focal features. The associated seizure does not arise from CNS pathology. Complex febrile seizures show focal characteristics or are prolonged longer than 15 minutes. The child may or may not have previous neurologic abnormalities. The risk of occurrence of unprovoked febrile seizures after a febrile seizure is 4 times greater than in the general population. A family history of febrile seizures, complex febrile seizures, and pre-existing neurologic abnormality is a risk factor associated with the later development of chronic epilepsy. MJJ's seizure appears to be a typical simple febrile seizure that developed in association with her upper respiratory tract infection. The lack of previous neurologic abnormality and normal findings on lumbar puncture and laboratory evaluation help confirm this assessment. My next question to you reads: how should MJJ's febrile seizures be treated? Because MJJ is not having a seizure at present, anti-epileptic drug therapy is not required. Measures to reduce her elevated temperature should be initiated. However, these measures may not reduce the risk of further seizures. Acetaminophen and tepid sponge baths usually are helpful. If patients experience prolonged or repeated febrile seizures, either diazepam or, less commonly, midazolam may be administered. Rectal diazepam gel can be used for this purpose. On the basis of the subjective and objective data available for MJJ, is anti-epileptic drug therapy indicated on a long-term basis? What are the benefits and risks of anti-epileptic drug prophylaxis for febrile seizures? Long-term treatment or prophylaxis with anti-epileptic drug for simple febrile seizures is not recommended. Up to 54% of affected patients will have recurrent febrile seizures, and the risk of recurrence is even greater when the first episode occurs before 13 months of age. Nonetheless, recurrent febrile seizures are not associated with brain damage or development of epilepsy. Although administration of continuous anti-epileptic drug treatment may reduce the recurrence rate of febrile seizures, published guidelines recommend against this practice due to the associated adverse effects. Prophylactic administration of various fast-acting agents, given during fever episodes, has been studied as an alternative to continuous treatment for the prevention of febrile seizures. Agents in both the anti-epileptic drug and antipyretic drug classes have been studied in this regard, but no clinically important benefits have been found. Thus, anti-epileptic drug prophylaxis for febrile seizures is probably not warranted for MJJ, even though she is at risk for both development of epilepsy and recurrence of febrile seizures. No evidence supports that medication will significantly affect her later development of epilepsy. Close medical follow-up of MJJ is warranted. Her parents should be counseled to contact a physician if MJJ's febrile seizure is accompanied by focal features or last longer than 15 minutes, or, if MJJ experiences a febrile seizures. Although antipyretic measures, tepid sponge baths, acetaminophen or ibuprofen, are of questionable benefit, they can be considered at the onset of fever because these interventions are usually safe and well tolerated. Many febrile seizures occur early in the course of an illness before fever is detected. Nevertheless, vigilance by her parents and early antipyretic therapy may help prevent further febrile seizures. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 393.